We are on a mission.
A mission to save and revitalize independent pharmacy.
On the Catalyst Pharmacy podcast,
You will get actionable business advice
hear stories from industry leaders,
and share a laugh with us.
fuel your passion for pharmacy.
One conversation at a time.
There he is. Hello.
Hello, Kyle.
How are you both doing?
Doing great.
We are great.
Been looking forward to this.
Yeah.
If nobody knows, it's Kyle McCormick. He's actually been on the podcast before, and I think Marsha and I had a...
Like twice. I think you've done a podcast with Mark and Josh, and then I think you've also done one with Will.
Sorry, on the Catalyst podcast,
On
he's
the
been on there
Catalyst,
before.
yes, on the
And
Catalyst
you
podcast.
and I were at a trade show, and and it had to be Josh and Mark. So
It had to be them.
I'm sure it was lovely, but I didn't get to enjoy it. You know, we started this podcast for our personal enjoyment, not to share it with somebody else. You know,
I'm sure it was still a very enjoyable episode.
Not for me.
I enjoyed the first 10 minutes I listened to this morning.
You're getting the wrong. I've got a me focus today.
Yes.
It's like
yes.
I didn't get to enjoy it. Now I'm getting to enjoy
I'm pretty
it now.
sure everybody who's listened to our podcast realizes it's always all about you.
I'm curious, what are the orange books? I've always wondered what
That's
the orange books are.
probably not what they're thinking.
So the
Marsha.
orange books, and let's see, the Happiness Advantage.
And the Introduction to Electronic Data Processing.
Yes.
Okay.
So a very old computer book.
It was an orange book, and it fit the decor.
Yep. Aren't you glad?
I
So-
see it in all the episodes, so I've been curious what you're reading over there.
Nice. Well, how the heck are you?
We're decorating. We're not reading.
Good.
What's the weather like up there?
It's fall. It's
Yeah?
definitely fall weather now. Yeah. Probably 60s, 40s overnight. So yeah, it's a little.
Tell me
little
more.
chilly.
What is this fall, and what is it like
what
up
is
there?
fall like?
It's great. Yeah. Sunny. Leaves are coloring. Pumpkins are being picked. It's great.
Yeah, I
Yeah.
think our high for the day is supposed to be 85, but it feels like 90 still.
Remind everybody what city you're in.
Pittsburgh, Pennsylvania.
Pittsburgh, Pennsylvania.
Oh, the true fall.
Not very far
Yeah.
away from some of our folks up there. Our CEO and
The other 20% of our staff is up
does he ever
there.
come see you?
I've invited him. No, I have not. Yeah, I know he's pretty close by. But
Wow.
I think he's south of the city.
Yeah.
Way
I love
your
to
background.
Call out
Raw
our
is in.
CEO like that.
Raw is in. Why did I call out? I just asked if you've been to see him. I can go see him.
Yeah. Yeah. Anytime anybody's welcome.
Yep. Yeah, I see. All right, and so Kyle, remind everybody he's got the Cost Plus Pharmacy, the original Cost Plus Pharmacy. Unfortunately, he's not a celebrity yet, and so had he been, it would have been
After
the
this
only Cost Plus
episode, I have
Pharmacy.
high hopes.
You have high hopes.
I have high
gonna
hopes
make him.
after this.
We're gonna make him a celebrity today. We've all been laughing. Our CFO did a quarterly report this morning, a little 3-minute thing posted on. I think Marsha leaked it on the internet, but where he had ChatGPT convert. He said 80% of our staff's in the South, and so he had ChatGPT convert what he'd normally say to Southern speak.
I have constantly harassed.
We're moseying into the next quarter.
I have constantly harassed Jeff, and I'm like, okay, that's great. That's our language, but that's not somebody else's language. Stop using acronyms.
Well, she's big on acronyms, and somehow we inherited when we joined RedSail, inherited a bunch of acronyms.
Yep. And I'm like, that's great. We know these acronyms, but the people we're talking to don't know these acronyms.
I know.
And
Are you talking about Mosey? I know what Mosey is.
Yeah. Well, the CFO acronyms. So in this podcast,
CFO acronyms,
we will not talk about CPP instead of Cost Plus Pharmacy, right? so we have a
Yes, after this
CPP up in here in
episode-
Pennsylvania. And
Yes, following this episode, it will be ran through ChatGPT and Southernized, just like our CFO did his quarterly report. And it was just, it's classic. It's classic. So anybody who listens or watches, go check out my
we should
LinkedIn
go check
page.
out the LinkedIn too.
Yeah.
I'll share
nice.
it too
Okay.
when I get done with
Yep.
here. So what's been up with you?
What is new
exciting stuff?
in Kyle's
What's new?
world?
Just continuing to grow the cost plus model and make a case for why we don't need insurance involvement in any generic prescription drugs. That's really what's new and what's old.
Yeah, and growing. I think you're
it's
growing.
definitely
Craig, our CEO, said he talked to somebody in Pennsylvania that he knows. He was like, who uses your pharmacy? And I was like, yeah, I can't believe, my prices are cheaper than my insurance copay.
Our word's been getting out about us, which is great. We've been growing steadily every day since we opened.
So let's remind everybody the model.
Yeah, the model is a cost plus model. What that means is we take our price that we buy the drug at, add on a dispensing fee, and so we charge for the service of dispensing, not for the product that we're selling. And then that's the price that the patient pays. We don't bill any third parties at all. Don't have any contracts signed. It's just right. If the patient, nothing's off formulary as long as it's within the patient's budget and it's a good drug for the patient. It's the price they pay.
So those are individuals, kind of word of mouth. Are there have employers signed up? Were they signed up? Hey, I'm an employer. I can't afford health insurance for my employees. I got 4 of them, but I'm going to pay for the cost plus pharmacy.
Yeah. So employers we're working on, it hasn't been a focus just because their buy cycle is a little longer.
Okay.
And we've had a decent bit of success with direct to consumer, but we have had direct primary care offices sign on. So pretty much every direct primary care office in Pittsburgh has all of their members as members of our pharmacy. They don't have to fill with us, but it allows us to do things like chart reviews and different care services for their members.
So they pay the membership fee, and you're doing chart reviews and things like that. That's awesome.
And they also get all the dispensing services too. So I know in pharmacy world, we often view it kind of encroaching on our territory whenever direct primary care does dispensing. But what I learned is that actually that a lot of the direct primary care offices don't do it because they like dispensing. They do it as they send a patient out into the pharmacy world, and then the patient gets dinged with a $100 copay. Right. And they're like, wait, I can buy this bottle of 1,000 for $10. Why are they being charged so much? So then they just said, well, if we can't find a pharmacy that'll do it, we'll just do it in-house because it's very inexpensive to do. So
how many other pharmacies are you working with on your program? How many would you say that you're working with?
So we're just a single pharmacy.
Okay.
We do offer what's called Cost Plus Pharmacy Consulting.
Okay.
And we have a website called costpluspharmacies.com where other Cost Plus pharmacies can sign up to have their prices displayed. Also, through the consulting services, we help get the pharmacies launched with either a membership offering or as a Cost Plus pharmacy itself. So we're working with probably about a total of 10 pharmacies at the moment.
Okay.
Between both of those offerings.
I see where you're the co-owner of Cost Plus Consulting. Who's the other owner?
The same other owner at Blueberry Pharmacy, Ravi Patel.
Okay.
He's a pharmacist and professor at University of Pittsburgh. Teaches their innovations course there. So we're co-owners on both ventures.
So one of the things you talked about, or I've talked to you about before, was was limiting the size, right? Maybe we have talked to. Oh no, now I'm starting to question myself.
You and I have talked on the phone about several things.
Okay, so maybe I know we've talked on the phone. But I remember I could swear you talked about in your model that you're only going to grow to a certain size and then have another pharmacy.
Yeah.
Is that still true?
Is that still the plan?
Yeah, probably. Just because I think there's an inherent one. I don't like mail order. I think it's a current necessity, but I honestly think we'll do less mail order over time. And so as you limit your geographic scope, then really once you've served that community, once you have a certain percentage of that community, then your next step is to put one in another community. So I imagine with time, I think you might even be referencing the last podcast that I was talking with Josh and Devon. And we talked about kind of the number being 2,000 members.
Okay.
I still think that's a pretty good number. In fact, we're probably right around that point right now between our DPC members and our direct to consumer members. So I think that, we probably could start up another location at this point. Right now, I don't know that I'm mentally prepared to start. So that's why we focus more on consulting and helping pharmacies across the country open up their own Cost Plus. Mainly because I also think, instead of recreating the wheel. There's already a pharmacy in every community across the country. So why don't we just, the fastest way to scale this model isn't to open up individual stores across the country. It's to turn the switch for every pharmacy across the country to just say there's a better way of doing pharmacy. There's a more direct way of doing pharmacy without third parties. And here's how you do it. So that's the fastest way to grow it. And that's kind of how we plan to do it.
Can I transition? I mean, if I'm doing that, let's say I'm in so-and-so city, North Carolina. Do I have to, like, Friday I close my doors as a third-party pharmacy and Monday I open it up as cost plus only, no third parties? Or is there a way to migrate from one to the other?
What's the transition
There's
like?
definitely, you can transition. I would argue that if you're a new grad, low debt, not too common, but like, if you're ready to just, if you're ready to just put in the hours, or even not even a new grad, but like if you're a couple years out of practice, ready to like just put in the hours and grind it out, you're probably easier starting up from scratch.
Okay.
Than transitioning. Transitioning comes with several challenges. One, as especially Marsha, you would know, like marketing message, right? So you got to completely change your marketing message.
Yeah.
You go from marketing a pharmacy that does everything to a pharmacy that does one thing really well. We take all insurances one day, we take no insurance the next day, right? And so it is a retraining of your entire demographic. We encourage people that are transitioning to kind of almost create a whole separate brand around their cost plus model.
Okay.
Just so that they can say, this is, this is our cost plus program. It's a member program, and here's the membership, and here you get cost plus pricing. So transition probably works best through a membership model, where once you pay for the membership, you get the cost plus pricing.
Right.
The other challenge too is really the selling down of your inventory. So our whole first year in business, we had $5,000 of inventory on the shelves. If you look at a traditional pharmacy, they have $150,000 worth of inventory or more.
Okay.
And so it's like, how do you go? You can do it, but like you got, say, 6 bottles of Eliquis on the shelf, and you sell down that Eliquis, and then next month that patient needs that Eliquis, you say, yeah, sorry, we're not stocking that anymore. It's just a little bit more challenging conversations to have, versus if you start up from scratch, you never carry the Eliquis to begin with. So I think it definitely is easier to start from scratch, easier in the marketing message and the actual logistics of it, but probably it also comes with challenges in that, like, you've got to create a whole new business, and there's other definitely headaches that come with starting from scratch. But I do think it probably is easier to do it that way.
Do you have another?
So I'm just trying to think, like, have you thought about creating kind of a step-by-step process of kind of thinking and walking through? So, like, I'm an established pharmacy, and I'm curious about this program and the benefits, and I want to start transitioning. Like, what are some recommendations that you might put in place?
Yeah, I think the first step is that membership piece. And I think even if pharmacies aren't doing a cost plus model, I think memberships are really important. And been advocating for this for a while, but
so you could carve out a membership program. Go ahead.
Yeah, sounds like it.
And your membership doesn't even have to be cost plus, right? So pharmacies give everything away for free. I mean, whether it's delivery or packaging or MTM, it's just like everything's free. Whereas all of those come with a cost. And so one way to put a low cost to the patient and start actually recapturing some of that value is through a membership. So bundling some of those things you're already doing for free and putting it into a membership. So cost plus aside, we encourage all pharmacies to consider a membership for things like delivery, mailing, MTM, packaging services, things that you're currently doing for free, but there is sometimes a significant cost to those services. So membership doesn't just mean cost plus. And if you look across the board, really, independents are the farthest behind on this. You have GoodRx Gold that has 1 million plus members. You have CVS Care Pass, where they're encouraged to sign up, I think, 10 new people a day to CVS Care Pass. It's one of their metrics.
Now, GoodRx Gold includes a telehealth pack piece, doesn't it?
I think it's discounted telehealth. Yeah,
Discount telehealth. Okay.
Yeah.
Any play for you there?
I thought about it. We have such good. I hate to step into the health provision side just because we have good PCP connections and referrals, and our relationship with DPC where all of them have. So I'd encourage people to sign up with DPC and then get a free membership with us, that kind of stuff.
Right.
But yeah, you have Walgreens Savings Club, you have GoodRx Gold, you have trying to think some of the other ones. Costco has a added benefit if you're a Costco member. You don't have to be a Costco member to use their pharmacy, but they have additional savings if you are a member of Costco. So if you look at independents, I don't know of many. I mean, I know some now because we've helped them launch memberships, but I don't know of many independents outside of the last year that have memberships for their pharmacy.
Do you think there's an appetite for a group of independents advertised price, where here's our cost plus price, and you get this at 4,000 independent pharmacies across the country?
I don't, just because I think it's important for independents to have a membership offering, but I think because we're independent, I think each independent's offering is going to be very unique. And that same with cost plus. I think the one thing I have against the nationwide celebrity cost plus that you mentioned earlier is each person's cost of dispense is different. I'm in Pittsburgh. It's a lower cost of living than San Francisco.
Right.
You have to have a higher cost of dispense there, probably $10 per prescription versus maybe $8 here. Or not only that, but the different services that are provided too. We might have very, very personalized service for each customer, whereas there's going to be a Walmart of cost plus that comes out. Maybe it is the nationwide version where it is cost plus $3, cost plus $5, but you can't talk to anybody.
Right.
So I think that there will be chain versions of cost plus. Probably every chain's going to eventually have to have cost plus. I have a bet going on with my other pharmacist. I made the bet that within 3 years, every 51% of the pharmacies or more will be cost plus in their pricing models.
Okay.
He says it'll take longer than 3 years, but
something that could speed it up is the whole DRR in January, right?
Oh, sure will, yeah. I just talked to a pharmacist last night that sent out letters to 2,000 patients saying we're no longer taking your insurance in 2024.
Wow.
He's only taking one Medicare plan and Medicaid, which Medicaid is carve out, which if you look at Medicaid as an indicator of cost plus, the fastest growing type of Medicaid is an ADAC or a similar plus model.
Did he say in that letter, we're not going to take your insurance, but we believe that our price for you will be cheaper than your copay?
I don't know that he said, I didn't see the letter, but I don't know that it's cheaper than copay is how he phrased it. But basically, you probably won't have to pay that much more if you have to pay more at all. Like often less, but sometimes even, sometimes more, but not much more. I don't know. But it is crazy.
And there's that messaging. If the letter started off with, we're no longer taking your insurance, I don't need to read any further.
They may not read any further.
They may not read any further.
You definitely have to phrase it right. Yes.
Yeah, to me, I'd have been more tempted to let them come in
and then
and tell them, hey, no, we don't take your insurance anymore, but I have it to cash cheaper than your copay would have been.
I know. I don't know what kind of message they did but there's a social media post for the pharmacy that recently did something similar where they stopped taking insurance. Which got very positive feedback, actually, from patients that seem to be in that community. It's Forest Park Pharmacy out of Texas.
Okay.
They stopped taking insurance. They're a compounding pharmacy that does commercially available product as well. And they transitioned to a cost plus model alongside their compounding pharmacy.
Huh.
So it's just going to keep happening. And people actually... we talk about services in pharmacy, and I'm convinced that there's nothing wrong with providing a number of services, but I'm convinced that anymore, one of the biggest differentiating services in pharmacy setting is just picking up the phone. Yeah. It's that bad in chain world.
Well,
it's that bad in chain world.
And you have to, people have to, it has to transition. You're seeing it with walkouts at Walgreens and stuff like that as they try to cut cost, below what what is viable. For years you gave away services for the product, and as product gets cheaper, the model's got to change.
Yeah.
And it's neat to be. I think it'll be neat to look back and see you were kind of at the beginning of that model change. Are you going to NCPA?
That
I
was
won't be
my
there
question.
now. Next year I will be.
What?
Sorry.
We're not going to
that's
see
okay.
Kyle in
I'm
NCPA.
surprised they didn't have you speak. I think that's super interesting. I think, they're pushing the Bright Tree. What do you think about the Bright Tree model? The embedded.
Embedded.
My concern, I like it, but I also just because we have such great relationships with primary care,
Yeah, we hear that a lot.
Yeah.
I really I can't become a competitor with them.
Yep.
Yeah.
And then secondly, I don't like the messaging of you're going to pay for the way it's messaged is have an NP or somebody and then just throw in some bucket of meds for free to your membership.
Right.
But we have to get into the concept of pharmacy of it's not about the meds and their costs. It's about the service of dispensing.
Yeah.
I'm not charging you for the
I
meds.
agree.
I'm charging you for so if I throw in a Atenolol for free, I'm yet again doing the service of dispensing for free.
Right.
Like, so it's
Yeah.
about
I agree with
I
that
don't
100%.
Yeah.
I think, and I think that was kind of an knee-jerk response to the Amazon's $5 and so many drugs are free. But the drugs they're
Right.
giving away for free are a couple of bucks. Everybody be glad to pay a couple of, you know what I mean?
Yeah.
That's the wrong, say, hey, a membership with a discount and not give a, I like that. I like the idea of not giving away. Now, a couple of things. Now, are y'all doing compounding?
nah.
No compounding. One of the things that bothers me, and every model is not perfect, and I think your model is amazing, is the vaccinations. The fact, I think pharmacy has to vaccinate and it has to be ready to because it is the only source for pandemics and things like that. So did you do COVID vaccines though, where they were paid for by the government?
Well, the challenge is you still have to have third-party contracts for even COVID billing. So we could do medical billing. Honestly, we were so early on that we did do some just to get our name out there. We just comped our time, we did it volunteer time, which I don't encourage doing because you should get paid for your service. But we don't do vaccines purely because you have to involve PBMs or medical billing. I love the model of what they did for uninsured COVID vaccines, where they were just like, here's a pot of money. Basically bill that.
Yeah.
If they did that for every vaccine, because it is a societal benefit. So really I hope that the vaccines in the future just aren't a part of any specific insurer. They're actually just paid for out of a big pot of money.
And that's
Right.
because vaccines are too expensive for somebody to pay cash. Is that generally what that is?
Yeah, and generally, I mean, even if you look at Medicare, most plans it's actually a requirement to cover them in some degree, if not make them free. So nobody wants to pay even $30 if they could get it for free.
Right. Yeah, it's
But
interesting.
It's just, because if you involve a third party, then one's going to pay you $2,
Right.
one's going to pay you $20, one's going to pay you $40, and I'm not in control anymore, whereas I control everything in our model.
Yeah. So it's one of the things, if that model grows and succeeds, one of those things we're going to have to solve, one of the things we're going to have to lobby and solve is going to be the way public health approaches vaccinations.
And I'm not super opposed to doing medical billing. I won't lie. The problem is it takes away our focus. And I think of the keep our one thing the one thing until we hit scale, until we're done growing in a sense with our cost plus model. Until everybody understands cost plus, there's no sense adding complexity to that. So patients aren't expecting us right now to do vaccines.
Yep. Hey, everybody, if you didn't notice, he
so
just
focused.
referenced The One Thing. So if you had to
Keep the one thing the one thing.
If you haven't read the
One
book,
Thing.
if you haven't read the book, The One Thing, it's a good book about
Or watch
focus.
City Slickers.
And it's so good.
Whitey will tell
And I think what you guys are hearing here is a focus and saying, hey, yeah, that's good. And pharmacy ought to be doing it. But I've created these rules to focus and to succeed.
He's found his one thing to make his pharmacy succeed.
Right. And I'm going to focus.
Yeah.
Our mission is somewhat stolen from Tesla, but it's to accelerate America's transition to a fair and transparent pricing model. And so until that mission's accomplished, we're not really looking to, change that. So you're right on.
Nice.
Do anything else before I hit my stuff?
Yeah. I'm kind of curious more
I had
about...
one comment around
Okay, go ahead.
Yeah, this past week, just the craziest thing happened. So we started tracking. We have a whiteboard in our, because we understand that as prices become normalized, as more and more people do cost plus,
Okay.
you can start promoting your service more and what differentiate you. Like right now, our messaging up until recently has been, and still it is, because we still are one of the lowest cost providers in the area and even in the market. But our focus has been purely on cost and, save money, eliminate insurance, you'll pay a lower price. But as more people do that, then it's more about service, which is beautiful because we have great service. So one of the things that we started doing is actually tracking on a whiteboard the number of drug therapy problems that we resolve for patients.
Nice.
And so we have it, prominently displayed to the public. And this past week, somebody came in and she's like, my husband has all these meds and he doesn't fill them here, but I'm curious if you offer a service where we can just go through them and discuss if he needs to be on all of them. And I'm like, yeah, it's called, what you're looking for is called medication therapy management. And we charge $20 per 10 minutes. So it just depends on how long it takes, but that's a service that we offer. She's like, that's fantastic. How do I schedule that? Actually,
it's great. My wife would do that with her parents. If you were in Shreveport, Louisiana, she'd be all over that.
Yeah.
And the one thing that made it easy sell to her was the fact that I said, what you're looking for is MTM. And so we do it all the time. And here's every time that we've, I pointed over to the whiteboard and I said, here's every time that we've optimized a patient's medication list. And we've only been tracking that for like 3 weeks now. I said, this is everything that we've uncovered just in 3 weeks. And she was like, whoa, how do we schedule that? And so
that's awesome.
So I think it really
well, and taking that data and creating a message that you could hand out to a patient that walks in and you give them 3 new prescriptions and kind of creating that pamphlet or whatever that goes inside that and kind of, hey, so here's what we do. Here's some information on it and data. I think that would be powerful. And I would
go to assisted living.
Yes.
I'd go to the nurses in assisted living, because normally the people filling their scripts with them are just doing what the doctor said and said, hey, we offer service, we'll analyze this. Can we offer it to the patients? Nothing you guys have to cover. Can we offer it to them?
Right.
And I think so. I bring that up because so often we hope that like third parties will pay for something, or that's we're trying to get an MTM or something covered by insurers, but we often forget the end patient is a payer too.
Right.
We can just go directly to the end patient,
and we're not talking about crazy cost as compared to going to the hospital or because my meds are wrong or something like that, and it just
or you were given meds that you maybe didn't tell the doctor that you were on this and he prescribed these other things, and you got this at CVS, and then we came over here and got this at your pharmacy and didn't tell you about this medication that back over here. And so I think that's very vital, and my biggest thing is that patient education that piece of the patient education is missing.
I didn't realize how bad it was until started dealing with my wife's parents, and it just don't and some of the pharmacies who are doing that kind of more the long-term care pharmacies really aren't looking at it.
Patients, the thing on the patient side of thing is that they don't know. They know this doctor gave them this medication, it's cool. Now this other doctor gave this medication, it's cool. And it's
even
all
the
fine.
Same doctor. Sometimes the doctors don't.
Yes.
I mean, the doctors just make silly, I don't know, because they don't get any education on drugs.
Yep.
They don't have, I was talking to Josh Hallen the other day, and this has never happened. But the perfect world is that physicians diagnose and pharmacists treat.
Yes. Yeah.
Okay. So the doctor says, here's the problem, measures the problem. But if it's going to be solved with drugs, that the pharmacists are choosing the drug regime and writing the prescriptions.
Exactly.
That's how it. Now maybe not before pharmacists were doctors, but now that a pharmacist has a doctorate, no patient should get a prescription without it going with a pharmacist looking at it and really thinking about it.
It's funny because that's one of our biggest proponent. Like, because we're not getting paid for dispensing, we get crappy dispensing. But we think of dispensing as only putting pills in the bottle. But if you look at OBRA 90, which is a law that was enacted back in 1990, it actually outlines the fact that every time you're filling a prescription, now granted this was, I think, for just Medicare, Medicaid, something like that, but the patient not only has to, that's where the offer to counsel came from.
Yep.
But outlined in there is that you will review every patient's medication list and update it with allergies, medication history, other medications. You'll look for you'll look for the 7 drug therapy problems. And so if that was actually happening, if people actually got paid properly for dispensing, exactly what you just described would be happening. We would get that thorough review each time, and we wouldn't have these problems piling up for patients.
Yeah. Our life expectancy is declining. And I think that's because we have too many drugs that are interacting poorly. And
Well, and again, this is where, patients aren't properly educated with, when, like, my mom went to the doctor and she's seen like 6 different doctors. And when she went to this one appointment and I went with her, and they're going, okay, well, your blood sugar's a little off, and just sitting there, I'm like, didn't a doctor tell you were borderline diabetic? She's like, well, yeah. Didn't that doctor also tell you that you were insulin resistant? Well, yeah. And it's just that had I not been there, she would have not provided that information to the doctor. And it's like, from me being on this side of the industry, I go in and I tell the doctor everything, and I walk in with any new doctor's appointment. I'm like, here's my family history. Here's my latest blood work. Like, they get a 50-page document practically, and they're like, very well put together. And so I'm more about information overload. Like, provide everything so you don't screw up my health.
Yeah, she's definitely information overload, overshare. No. All right, so you're going to miss my speech at NCPA.
Hang on. Slow down there. I want to go back to the fall bug. So you live in like prime hiking territory.
He never gets any sun in Pennsylvania.
Yeah, vitamin D deficiency.
Yeah, he's got to have a sun lamp.
I thought that's what was on over his head right now.
The trees are gorgeous though, but no, they don't get a lot of sun.
But I mean, remind me again, how old are your kids?
We have a 5-year-old and a almost 3-year-old.
And so, like, we've been hiking a few times, and we see the parents that are like backpacking the baby on them, and I'm like, I love my kids, but I'm sorry, I would not be that committed to hiking. But I mean, do you take the 5-year-old hiking, or like any bike trails, or?
This past summer we didn't do as much, but last summer we did go camping a decent bit. The summer just didn't work out as much, but we went camping once this summer. They love camping, so that's really our thing. Hiking,
not yet.
Not yet.
So what's a hike for you? How far is a hike?
With them?
Mm-hmm.
No, just you.
I'm not much of a hiking guy.
Oh, you're not. You're
no.
Okay. So
you're
a national park guy.
Yeah, national park.
So I thought about that. I mean, for a brief moment, my wife and I said, hey, we ought to do a bucket list to hit all the national parks. Then realized there's like a bazillion of them. So do you have a scheme for attacking national parks since you like national parks? Is there like a top list or something?
Yeah, so we try to hit up one at least a year. So we're probably not going to hit all of them.
Okay.
This year we chose to go to Iceland instead.
Cool. Literally.
We might.
Cool.
Yeah. So we might. It is literally cold.
I wish I was in Iceland in the summer.
I've been told Iceland is green and Greenland is ice.
It's still colder. Yeah.
It's still a little colder.
It's correct.
Yeah.
It's also rainy. I wasn't that impressed, I'll be honest.
Oh no.
What?
It rained all 4 days that we were there. It was cold. But it was nice. It was scenic and whatnot. But
so what has been your favorite park?
I love Arches National Park.
Where is that?
Arches would be Colorado.
Arches National Park. So, okay. Yeah. I have to put that on the bucket list.
It's the one where you see the iconic arch that's like, like kind of reddish colored.
Okay.
Interesting.
And then I also like Zion National Park. That's a really good one.
Zion and Arches.
Where's Zion? Is that also Colorado?
Zion's really close to Las Vegas. I'm not sure.
Okay.
Mexico is which one? That one then.
It'd be New Mexico or Arizona.
Yeah, I think it's one of those.
Okay.
All right. You're gonna miss my speech.
Yes,
Yeah,
Jeff
it's going to
is-
mix your speed.
My
Yes.
speech is, I started with 10, it's narrowed it down to 5 ways to run your pharmacy out of business.
Okay.
And so I'm going to query people for like the next 6 months on when we're talking to smart people about what they're doing in their pharmacy for these 5 things. So you get to be my first
What are
guinea
you
pig.
doing to combat these 5 things?
Yeah,
Okay,
yeah,
awesome.
It's really
Yeah.
what you should be doing. So, all right. So they are, and I'll give you a preview of. They are. Well, if you take them from
Luckily,
the run
this
your
is
on your
coming
way
out
out,
after
your
NCPA,
business,
so you're not no spoiler alerts.
You'll be,
no spoiler alerts here.
ways to run yourself out of business. Focus on negatives. Not having goals. Not getting out of the pharmacy. Not engaging with your staff, and
Avoiding
I'm missing
negativity.
one. Goals.
I've heard this already 7 times. You'd think I'd have it down now. I've given a couple of good.
All right, so we'll start with.
Let's take them one by.
Okay, go ahead.
Let's do one by one. What's the okay? So
Negative. Keeping a positive attitude. So
yeah,
the world's
okay.
full of negative with PBMs and pharmacy not getting paid. What do you do to maintain a positive attitude yourself and
Instead
a positive
of
attitude
looking
for your
at
staff?
a glass half empty, how do you look at
Yeah.
it as, oh, it's actually half
Anything
full?
positive there that you do?
Well, luckily in the costless world, everything's positive.
No.
there's no
It's pretty
DIR.
good. I got to fist bump like you were here. That was good. Okay.
Yeah, there's no DIR fees, no losses, no negative claims, no coupon fees, nothing. So
So we're
It's all
dreaming
positive.
about 2024.
yeah, so
All right. So generally staff's positive because everything's on a positive positive note.
Yep.
you know what I'll say also around that is students love coming here, not because I'm a great teacher or anything like that, but I ask them every time, what's your favorite thing about this rotation? And they say it's talking to patients and talking to the patients that have an $800 copay on a medication. And then we get to tell them, oh, you get it here for $60.
It's
It's
crazy.
like, they're like, oh my gosh, are you kidding me? How is this possible? It's like, I told that to one person. They're like, it's kind of like your Oprah every day because it seems like you're giving away stuff. Like you
May want to pick a new superhero since she's under fire right now.
Oh, come on. Don't give Oprah a hard time. All right. So,
But yeah,
goal setting.
It is positive.
So-
Goal setting?
Uh-huh.
Yeah, so goal setting, we're due for a quarterly goal setting here, actually. So that's something that I'll have to get back to you on combating.
Okay.
But definitely.
Okay.
So like goals, scoreboard.
We have good point. We have a scoreboard.
Okay.
That's the, our goal is to be the best customer service pharmacy. So we track the drug therapy problems every time we identify one.
Okay.
Okay. Goals for like membership count or something like that, or y'all just kind of get them as they
So-
come.
Yeah, we get them as they come. But our overarching goal is still that 2,000 members.
Okay.
So we're pretty darn close to that. So should be within the next year that we hit that.
Nice. All right. So we know you're doing good on getting out of the pharmacy because you're talking about the relationships you have with direct
Primary care.
primary care. Blah, blah,
There
blah,
you
blah,
go.
blah,
You
blah,
got
blah.
it.
But what's your march there? Do you have, hey, I'm out of the pharmacy a half a day every week, or how do you allocate that time?
Yeah, so with my role in cost plus pharmacy consulting too, a lot of the days are all over the place. So talking to you all today, talking to legislators that are trying to be involved in the community. So we've talked to nearly all legislators in the area, try to educate them on the cost plus model, but also just on how pharmacy works, how healthcare works, talking to newspapers and journal outlets, advocating for the profession statewide, so giving talks at the state level, giving 1 or 2 talks at a state conference this year.
Okay.
Huh?
And so in precepting,
But just not
so,
an NCPA.
Oh, and the precepting.
yeah, precepting. So
You're speaking at our conference, huh?
I'm not speaking at your conference.
What?
I will if you want me to.
Well, I think you should. I think it'd be neat to see an update of how that's going on. I got to see
Yeah.
Will, see if we got spot.
I have a meeting next week with Will to go over all of the classes for a Catalyst event. So,
All right, keep going. So legislative stuff and
Precepting, so talking at Duquesne next week, talking at Temple 2 weeks from now, talking at Pitt. So just trying to educate the schools of pharmacy, the next generation of
A pharmacist.
How did you
Pharmacist.
get the
Nice.
relationship with the prescribers that you have? How did that happen?
Charge fair and transparent prices. They
I
come
know, but
to
how did
you.
they find out?
I honestly don't know. So the one prescriber that regularly refers to us, he and I work together in Indiana, PI.
Okay.
And we did MTM there, and he went and opened up a insurance-free primary care in Pittsburgh.
Okay.
I opened up an insurance-free pharmacy in Pittsburgh. He read about us in the paper
Interesting.
a month after we opened, and he said, "Hey, we should talk again." And so
they're getting in the newspaper kind of got you that kind of free
Yeah.
publicity in the
Great,
model.
great publicity.
And then I think similarly, it might have been newspaper for the other provider for the direct primary care is, hey, we don't work with insurance. You don't work with insurance. We hate dispensing. You like dispensing. We should work together. And then so I think it was just the uniqueness of the model. I mean, we get brokers reaching out to us. We get just because once you are transparent, people come to you because they can actually see prices. You can't go, you can't shop healthcare, you can't shop pharmacy without involving GoodRx or some third party and see prices, especially independents. You can't know what your
Well,
price
and
is
even
going.
you don't trust the GoodRx prices. With them not having a relationship with Kroger's, the Kroger's prices that GoodRx puts on there are stupid. I mean, they're not accurate.
They're lies.
Right.
There's some kind of estimate that they've gotten from some kind of data feed somewhere, and they're not accurate. And so you can't trust that. That's not transparent. They're not telling you they don't have a relationship with them, and they're just telling you, hey, this might be, the price you get in the pharmacy. I think they have a disclaimer that says the price we get to the pharmacy may be different. This is just our estimate of what it'll be. So
very sure. It's the future of healthcare is transparent though, and so if you think about anything else you buy, any other retail industry, you see a price up front, and it's actually a price. Even you can negotiate it down, but even purchasing a car isn't as far off as purchasing a generic drug with their usual and customary, right? If you look, usual and customary on imatinib is $16,000, $19,000, right? But we buy it for $24.50. And no other retail industry has that big a discrepancy between acquisition costs and usual and customary. They're made up numbers. And so cost plus will win out because people are going to start distrusting places that don't show prices or don't have real prices or are artificially inflated prices. Whether it's employers that can see that, we're talking to employers and we can show them claims data right away. Hey, here's where you overpaid. Employers have already started questioning. I mean, that's why Cuban has grown, is because they're
looking at that transparent pricing.
There's still a middleman, but
right.
I guess a better middleman. But so I think being transparent is going to be key.
And so you'll also be getting out of your pharmacy this coming May and coming to Nashville to Catalyst. Yes,
that's right.
Hopefully, yeah.
Hopefully,
we haven't planned out our May is usually our family travel time, so we'll see if it works with our national park schedule.
So next thing,
what's number?
Employee engagement.
Yep.
Employee engagement.
So what are you doing as far as
what are you doing to
engaging?
engage with your employees and keep that positive energy going?
Yeah, we have one employee at the moment, staff pharmacist. We're currently hiring our first technician, so I'll report back on engaging with a technician. But
so it's interesting. So at this point, you just have two pharmacists.
Yeah, myself, co-owner. He works at Pitt during the week, so he works on Saturdays. And then we just have one pharmacist on staff. And then we take students from the schools of pharmacy. So in terms of engaging them, it's very much educating. Yesterday we had our talk about how the cost plus model works. And just showing them prices. They all work in community settings usually, but they don't ever get to see prices. So, they kind of walked away yesterday depressed and like, holy cow, this is completely messed up. But today they love it. They love learning about how broken the system is, but also how there is a solution for the system.
Interesting.
And then in terms of engaging Tommy, our pharmacist, he's kind of our new lead on employer focus. So creating an actual compensation mechanism for him to get out there and, kind of get a commission on every time he gets an employer on board. Financial engagement there. And then in terms of engagement, just to be excited about the mission is like, he can see in real time that we're fundamentally changing how the model of pharmacy works. From, being out there a whole year before Cuban launched to being out there and seeing 6 other pharmacies across the country convert to a cost-plus model to really seeing that changing throughout the profession. It's just a way to engage somebody on a greater mission. And I really think that mission is the ultimate importance in engagement.
Yeah. I was looking to see where I went a blank. So the fifth one is experimenting with new ideas, and he's totally into new ideas. So he's all about it.
So he's already covered.
Yeah, he's the experimenting. He's got the experimenting on overload. So
we experiment all the time too. That's one of my favorite things. Is since Ravi, he and I, a group of us started the innovations lab back at Pitt back when we were in pharmacy school, and he now leads the innovations lab at Pitt. So we get to engage with students and new ideas all the time.
That's awesome.
But some of the things that we do, we're partnered with a local startup that does cardboard boxes instead of plastic vials for prescriptions. So we actually just got our
do you have an example to show?
Yeah, right here.
That is so cool.
But the cool thing is whenever you open it up, it reveals little circles and blueberries. But it's custom branded, so it's got
not child resistant.
Yeah, it's not very child resistant.
Is it not child resistant?
It's more economical friendly.
But it's actually better for older patients with problems because it is designed to be child resistant. So I don't know if you can see, but you can't just open it.
Okay. It's child resistant.
You have to push up on the bottom, and then you have to push down right here, and then pull. Sorry, I'm not. And so it actually is designed to be child resistant, but there's testing certification that has to go into it.
Right.
So that's really cool.
You can't just give it to your 5-year-old and see if they can get into it and then call it child resistant and not work?
That's actually the testing process. Kids and see how long it takes them to get into it.
Take it to elementary school and just pass a bunch out and see how long it takes to get in.
I mean, have you seen Christmas Time? They have no problem getting into those.
Yeah, that's the deal with the paper. How's the price point on is that similar to Val? More? Are we selling the environmental?
It is more. So those are 60 cents a piece.
Okay.
So it is more.
And a vial's what, 10?
Vial plus lid is probably, low end would be like 12 cents. High end would be 60 cents probably for the big vial on the lid. Probably more like 40 cents. So definitely more, but.
Could you, but you're in the beginning of that. Would a mass production bring that cost down?
That's their hope. Paper is the only thing that would compete price-wise with plastic in terms of packaging.
Yeah.
And so that's their hope is once they hit scale, that can bring that down. But there's also the marketing component. So we've had patients come directly to us just because they want to support things that are going green. So we have a way for them to just sign up and get their medications in the greener packaging.
I have so many questions.
So that's
about
a choice.
Just the custom,
It is a choice,
ability to customize it to hey, make this look like my pharmacy, my brand, and can we do hey, these are your morning pills, these are your nighttime pills.
Are they just a local company? Is that you went with a packager, or is that their business?
I need contact information.
I'd love for them to be it. They should be advertising NCPA. They ought to be at Connect.
I need contact information. I want to talk to them.
I will get you contact information. I'm an advisor to them.
I think that having that choice, I love that. Hey, for $1 you can get environmentally, packaging and.
If you, they're called Parcel Health, and they are located. Okay. Their headquarters is here in Pittsburgh.
Okay.
Both the owners actually live here now, but I don't know that this will show up too well, but they probably won't show up at all.
No.
But if you go on their website, they have. One of my favorite boxes of all time is they have a University of Michigan box, and it's a box that's got the big yellow M going across 2 sides.
Yeah.
From a branding perspective, it's a fantastic.
No, look at the information and shorten the screen during the podcast.
Yeah.
Right, I'll put that as a to do. Well, that's great.
And then so some of the other things we experiment with is we're always always experimenting with workflow. So basically, every student we get, we have them evaluate. What are we doing wrong? What could we be doing? What could we be doing better? Asking patients that regularly. So our workflow changes just about every month in terms of ways that we optimize it. Whether it's using Pioneer differently, so things like print queues differently, creating different priority statuses, using technology like we have a pill counter that actually just happens on a cell phone. So instead of getting like a really expensive counting device, just have an iPad that counts it right on a tray. The tray was actually 3D printed, so really low cost, a way of just speeding things up, making things more accurate.
Interesting.
And we're working with a robotics company to actually do like a inventory management system where the pill bottles are actually come right to you, and so you don't have to deal with walking across the aisles and all that stuff. So just always experimenting with different technologies, different things. Even from we were talking about ChatGPT earlier, delivering patient education in a different way. We've experimented with creating poems to
what a great idea.
To counsel patients. So one of my favorite ones was actually to a family member. I wrote a poem for him about one of the antibiotics that they were going to be taking, to highlight the important counseling points.
You got it. Did you post that on LinkedIn?
I don't think I posted that one.
You got to post that on LinkedIn. I got to share it. That's
Instead of
what innovation.
finding their chocolate, you're speaking their language.
No, what do you just put in a poem? Hey, I write a little poem about taking your medication.
The cost to create is zero.
Creativity is free.
Yeah, you win innovator of the day. That's great.
Be innovative.
Because I was thinking you were just going to say, hey, just rewrite it, just reformat it. No, he made a poem.
No, he spoke their language.
Yeah, no, that's awesome.
Yeah.
I do.
And then
go ahead.
Back to your comment about positivity and opposite of negativity. One of the things that we've been talking about a lot lately around the walkouts and just even the students sharing stories from their experiences in traditional pharmacy models is I'm pretty convinced that about 99.9% of negativity in pharmacy is related to third parties.
Yep.
And so once you remove that, whether it's, what do you mean it's too soon? I just got that 2 days ago. Or, I haven't got that for 28 days.
Right.
No. Opioids and controls are a little different. But like, what do you mean I can't get my lisinopril? I'm going on vacation. Or, why isn't that ready? Well, it's a prior auth. All those things that people get mad about is because
third
parties.
Yeah. We've never had a prior auth since we've opened.
Huh.
We've never had a rejected claim since we've opened.
There are tons of pharmacists listening to this podcast going, oh, that would make me so happy.
The one student commented yesterday, she's like, I just get, we're talking to somebody at the chain that she works at. She's like, I've spent zero time on the phone with insurance companies since I've come to Blueberry Pharmacy.
Yeah. I had a little niece that she had a deal a couple of years through her life, maybe like 5-year-old to 6-year-old. Or every patient she opened, she'd be like, oh, it's what I always wanted. And I hear pharmacists, they're going to be watching this going, it's what I always wanted.
Yep.
Yeah. They can do it.
I do a slight pushback, though,
go
on the compounding. It seems like customized medicine, compounding takes us back to our roots. A lot of compounding is cash. Why the choice not to do compounding?
One, it's just not a skill set that I have. I don't know anything. Not that I couldn't get that skill set. Two, upfront cost in terms of getting started up. It was an unproven business model. I mean, compounding is a proven business model, but House Plus model was unproven when we first started. So I didn't want to invest in, sterile facilities and all that stuff.
So you don't think it's a conflict with the model? It just hasn't been on your list.
I think it's actually a really great in terms of people going hybrid or people converting is if people already offer compounding, adding on cost plus is a no-brainer. Yep. It's super simple. It doesn't add anything extra to the workflow really. And you're already heavily, if not all cash-based anyhow, so you don't have to worry about third-party conflicts or anything. So no, I'm not at all conflicted with compounding.
Yeah. So do you have
do you see yourself eventually investing in and doing compounding?
No, we don't have one. We don't have the space for it. Two, I do think you keep the one thing.
Yeah.
Yeah.
All right. So do you have like a tribe? So as the other pharmacists around the country who are doing this, do y'all get together at some time? Is there's like a cost plus crew that gets together once a year someplace, or do y'all talk or have teams meeting or anything like that?
Yeah. So, you missed it yesterday.
Oh no.
How can we get the invite to join this meeting?
So there's the four of us that kind of the very first cost plus pharmacies across the country.
Mm-hmm.
We kind of kept it to those four people. Myself, my
In other
partner,
words,
Robbie,
your invitation got lost in the mail.
and then we get together every month and just share stories and plans and things like that. But
Okay.
on a greater scale, the costpluspharmacies.com, the goal there is to connect pharmacies across the country, have a singular platform. Even there, our plan is to eventually scale the way that GoodRx scaled.
Yep.
Once we have that singular source for cost, send business cards to every practitioner in those areas and say, instead of you having X pharmacy's card on the counter because you're concerned about a kickback or conflict of interest, put this cost plus pharmacy's card on your counter, and patients will be able to see those savings.
So y'all created a website called costpluspharmacies.com?
Mm-hmm.
And I can put my individual pharmacy's pricing on there.
Exactly. Yep.
Okay. And what does that cost me?
$50 a month.
For $50 a month, I upload, manually put in. How do I put my pricing on there?
We just need NDC, unit price, and drug name.
Go ahead.
We probably don't in the future even need drug name. We just currently have it as a field, but really just NDC and unit costs, and then that's then.
So they type that in, or they upload it. How does that work out?
Yeah, they put it in a shared folder.
Okay. And it just reads it. And right now you have 4 pharmacies doing that?
No, there's probably about 8 pharmacies on gospelspharmacy.com.
Okay. And then they create their own marketing materials card, whatever.
So yeah, I mean, we have marketing materials for cost plus pharmacies, but the goal there is that it's actually, if you go to a single pharmacy's website on there, you don't know that it's costpluspharmacy.com. It's in the URL that it is, but it looks like that pharmacy's page.
Okay, so it'd be like cost plus pharmacy / Blueberry kind of deal.
Yeah, exactly.
Interesting.
Yeah.
Okay.
And we actually now have done it for our employer. We basically just made that employer have a white label version of our site. So instead of it looks like that employee, instead of seeing Blueberry, you'll see that employer, but it's just our pricing, and then it connects them to Blueberry's website. So it's all the same pricing. It's not like that employer gets anything different, but it only shows the member price because that employer will have member prices for their employees.
Any pushback from the other cost plus pharmacy on your costpluspharmacy.com? Is there any race there to trademark that or anything like that?
I don't know. I don't think so.
Okay.
I mean, the domain was available, so if they wanted to trademark it, they should have bought the domain. But
yeah, very interesting.
All sorts of interesting.
Well, I think we're out of time, but this was really fun. I hope to one day be like, I was there at the beginning of that. I knew Kyle.
Yeah.
Mm-hmm.
And when you're a celebrity, one day I'll say, I knew Kyle.
That's going to happen after this episode.
I was there when
this is going to help.
I was there when pharmacy transformed into something new, and PBMs had outlived their usefulness.
It won't be long.
Because they went from useful to greedy.
Yep.
Yes.
To now just in the way.
And Kyle took them out.
That's right.
Kyle and Mark.
Yeah. Long.
You had to think about that one, didn't you?
Yeah.
Okay.
It's a lack of judgment caused by hunger. But
gotcha.
Well, Kyle, hopefully we'll get to see you again soon.
Yes.
And
sorry, we're gonna miss you at NCPA this weekend.
Best
have fun.
Wishes, and keep fighting the good fight.
Yes, absolutely.
Thank you so much.
Thanks,
All right.
Kyle.
Talking to you both.
Bye-bye.
Right, take care.
Bye.
Thank you for watching the Catalyst Pharmacy Podcast.
If you enjoyed today's episode, please like, subscribe, and follow us wherever you get your podcast.
Give us a 5-star rating on Apple Podcasts to help us reach more pharmacy professionals like you.